Industry. Keynote for this year is white. We've been reading a lot about some of the developments of Watson Health and artificial intelligence and what's going on with extracting insights from a variety of systems, and we thought, that would be a really excellent fit. Unfortunately, one of our new CHIDS fellows from the last year came to us from IBM, Arnie Greenland, and was able to connect us with Anil Jain through some relationships, and so I'm really excited to welcome him here. Anil is Senior Vice President, Chief Medical Officer of Explorys and Watson at IBM Health. And I remember I first learned about Explorys several years ago. It was one of the sort of, continuing and even at the time, sort of most innovative sort of models of sort of providing data warehousing capabilities across multiple health systems where they could turn on some capabilities to really utilize the data, but also put in place a warehouse that all the member communities could use. I don't want to steal too much of your but this was originated at the Cleveland Clinic, where Dr. Jain had a number of leadership positions and have been involved with both practicing medicine as well as fostering innovation. He has a medical degree from Northwestern University, and he's done a lot of things. I'm not going to read them all here in the interest of time to let him get to the good stuff, but I just wanted to say how pleased we are to have you here, and let's give a big white welcome to Anil Jain.
Thanks, Kenyon, and thanks for the workshop's invitation for allowing me to share a few minutes with you guys and talk a little bit about what we're trying to do at IBM through our Watson Health initiative. I think you guys mentioned this is your 7th white conference. Watson Health is only about 18 months old. So what you're going to hear a little bit about is Watson Health within IBM learning to grow and really being part of, I think in many ways, much of what you guys are trying to do. I think there's a little bit of something for everyone in the room, whether it's innovation, whether it's deep learning, whether it's science, math. The main focus of Watson Health is really to change how we're looking at healthcare and the way that IBM, and we'll talk about this in a minute here. I remember I think it was the morning after I joined IBM, and I'll describe how that happened. I told my wife, I'm going to be working for IBM, and she goes, IBM, don't they make computers? Well, we actually had sold that division off, and IBM is a completely different company. So if you're old enough to remember IBM as the typewriter you used to write your term paper, put that aside. And if you're young enough not to know who IBM is, I'll sort of describe to you who they are. So my goal is really to tell you a little bit about why we're in this space. And a lot of it has to do with all the transformation that's happening, not just worldwide, and we see that happening through the single payer systems, but in the US, as Dr. Simpson explained to us, it's happening in a big way. The delivery transformation, reimbursement transformation, the way that as a doc, and I still practice part-time at the Cleveland Clinic, how I get paid is going to change from how much I do to how well I do it. We also know that there's a role of health IT, but we're not entirely sure what that role is. We've had some interesting experiments in our country. Some have done remarkably well, and some have failed. And then tell you a little bit about the word Watson. Why is Watson in IBM Watson Health? Why not just IBM Health? But it's IBM Watson Health. What is Watson? And many of you know Watson as the computer system that about 5.5 years ago beat Jennings in Jeopardy. Well, we've gone away from just beating people in games to trying to solve our biggest challenges in our society. Now, many of you in the room, I don't need to explain this to, some of you may have been involved in gathering some of this evidence, but we know that about 1/3 of what we spend in healthcare in the US is determined to be waste, fraud, or abuse, things that we shouldn't be doing. We also know that folks like myself at cocktail parties get accused of causing deaths, and that medical errors, if you will, are the 3rd leading cause of death. Now, I want to make sure, and the reason I wrote up here, medical error does not equal physician error. I'm a physician. Okay? Medical error in the way we classify it, the way you guys all classify it, the way you guys will do your research on it, makes a big difference. Just because there's a medical error doesn't mean that a mistake was made, if you will, and who makes the mistake. But this is sobering. So we know our healthcare system is broken, despite all the advances that we made, despite the fact that we're the top spender of healthcare, it hasn't worked. We also know that in a recent article that for every provider in this country, we're spending about $32,000 in terms of health IT. And that has gone up by 40% since '09. And we just talked about how we're really not making much of a difference in terms of safety and quality. We also know that, that just the sheer act of measuring quality is costing a significant amount of money. So Dr. Simpson talked to us a little bit about how some very influential, important policymakers are talking about reducing the amount of reporting burden. But yet we also have last week the final rules for MACRA come out that requires us to start measuring things. And we used to talk about let's start to measure what matters as opposed to what we can count. And I think there's a lot of anxiety among the health care organizations in terms of making sure that they're doing what matters. We also know, despite all the folks in the room, a wonderful presentation from Tenet in terms of how they're using data and analytics, but studies show that only 10% or less of healthcare systems are really using data and analytics to improve their operations. And despite the fact that we have significant evidence that predictive analytics, and we can all argue about what that really means and what is predictive, what is prescriptive, but these things have been shown to reduce cost, whether it's CMS or whether it's Optum, whether it's other folks. We have the ARA high-tech bill with meaningful use. We have the Affordable Care Act. We have now MACRA. And all these different policies are putting a lot of pressure on organizations like industry that makes solutions to help us figure out how this is going to help us. Now, we at IBM, we have a Business Value Institute, and we do a lot of surveys. We're going to have a survey coming out early part of next year, but I wanted to show you some data that's not from IBM, from Deloitte, that shows that when we talk about the challenges of why we're not able to use data better and why we're not able to get analytics done, that the number one reason out of a survey of 50 different organizations was culture and politics. Now, we may not be able to solve that in this room today, but I think all of us need to be part of how we are going to get more effect for what we do by thinking about what culture and politics have to do with our work. Fragmented ownership. If you go to a health system and you walk into the hospital board of directors and you tell them that you're going to reduce their hospital admissions, it's a very different story than if you walk into the primary care practices in that organization and tell them you're going to reduce hospital admissions. One person is probably going to lose their job, and the other folks are probably going to get higher margin for their value-based care contracts. So healthcare is still very fragmented in the US. The funding processes in terms of how I fund for my initiatives, who pays for it? Is it the folks that are going to get the biggest benefit from it? No one really wants to pay for these things. And then the tools and technology and data access. And obviously I'm going to spend, because we're coming from an industry perspective, that's what I was asked to do, we're going to talk about things where industry can make the biggest impact. Now, one of the challenges we all have is that, and I'm a primary care doc, when I do see patients, I'm supposed to know everything about them and manage all their problems in a first pass quarterback type of way. But the reality of it is only 10% of the clinical factors that I do in the office, where my nurse takes the blood pressure, I'm examining their heart. Only 10% of those things are clinical factors. The rest of it is their genomics and their environment, their exogenous factors, if you will. And so we have a problem in that the healthcare systems have been designed to really optimize in collecting data on that 10% on the clinical side. And we're just now beginning to start thinking about what it means for the social and the environmental and the genomic side. But when I practice today, for the vast majority of cases, we're not doing anything with their genomic data. Once in a while, there'll be a medication that I might need to prescribe where we'll do a special test to see whether they're going to be responding to it or not. But the vast majority of the decisions, start this cholesterol pill or that one, is being done based on what is in my head, what article I read the night before, what my favorite colleagues do. And sometimes one of those 15 alerts that goes off in my EMR is telling me what I should do. Okay. But most of the time, if it's 15 alerts, I'm ignoring them. Now, big data. So, and I'll get to what this has to do with Explorys and Watson Health in a minute. But we typically define big data as a bunch of Vs, 3 Vs or 4 Vs, depending on who you speak to. High volume, high velocity, high variety of data. You guys are all used to that. If you're a data scientist or you're a budding data scientist, you're dealing with big data all the time. And we heard earlier, veracity. It has to be correct. It has to be true. Otherwise, we can lead ourselves into directions that, that are difficult to come out of. I'm not going to bore you with all the details in terms of how much data we're swimming in, but there's a significant perfect storm happening right now. We are generating large and large amounts of data everywhere. I have an Apple Watch on right now. We have a partnership with IBM, and Apple has a partnership with IBM, rather. And my Apple Watch is collecting biometric data on me right now. And I know one thing. My PCP, one of my friends, doesn't want me to just send him all that data. Right? We need to do something with it before he gets all that data. We also know that the amount of publications, the amount of knowledge, the amount of medical data that one has to consume in order to make the right decisions is also increasing at a phenomenal rate. Now, we could argue whether it's bad science or good science, whether it's a positive study that's going to be confirmed or not. Wonderful panel, by the way, that we heard from earlier. But the bottom line is that all this is getting published, and we still have to go through it to figure out whether it's good or not. And so how do we really do that? And then, of course, the hospital setting. If you've been in the hospital recently or you had a loved one in the hospital, you know that everything in the hospital is now a smart device. The bed is measuring pressure. The patient is under to avoid bed sores. The pump is generating data. It knows exactly when that antibiotic is about to run out so the nurses can come in and change the bag that's hanging. Data's everywhere. And if we're going to really improve the operations of a health system, we need to make sure we can leverage all that data. Now, let's talk about IBM for a moment. So what does IBM have to do with healthcare? Well, we have been in healthcare for a long time, but historically we've been in the IT offices, helping with their data centers, with their hardware. In some cases, we've been helping with their integrations of their systems. But about April of last year, Ginny Rometty, the CEO of IBM, described our role in healthcare as our moonshot. And you know, perhaps if you're not familiar with that, the moonshot has a significance in the sense that we had a singular purpose to get to the moon, for example, the IBM or the moonshot. But it was all the benefits that happened along the way that allowed us to change the way we look at our society. And IBM's moonshot is the same way. Our journey in healthcare is spitting off a lot of benefits that have nothing to do with us being the leader in healthcare. We want to enable our healthcare systems to be the leaders in healthcare. But a lot of interesting technologies that are coming along the way. Now, about 3 days before Ginny did this interview with Charlie Rose, we formed Watson Health. Now, Watson Health was formed when one of my companies that I helped co-found, Explorys, was acquired along with Phytel, a company based out of Dallas that does patient engagement. Explorys, as Kenyon was saying, was a company that was focused on big data analytics and bringing lots and lots of information from healthcare systems around the country together so that we can do a couple things. One, do very, very interesting analytics to help them deal with all the healthcare transformation. And then number two, find a way to make that data available for secondary use, and by combining it with other data, going through all the regulatory HIPAA requirements that we would have to go through, so that instead of trying to answer a question on 1.5 million patients that might be at your health system, could you try to answer a question on 45 million patients, or 55 million patients, or 65 million patients? As we have gotten bigger, our data sets have gotten bigger. Now, when you think about Explorys, big data, clinical healthcare data expertise, Phytel, the patient engagement organization, and then as Dr. Simpson mentioned, Truven, and some of my colleagues at Truven, Truven had been a leader in payment and value. And many of you have seen or heard of MarketScan. MarketScan is Truven's data asset. And so you look at Explorys, Phytel, and Truven coming together, that's a formidable analytics and insights platform with a significant amount of data. Data that represents a significant number of concurrent lives in the US, but more importantly, by bringing together administrative data that MarketScan has had with the clinical data from Explorys, we can start to answer questions. We can start to ask questions and answer questions that we couldn't before. Then along the way, Watson Health also acquired a company called Merge that has a lot of images and imaging analytics capabilities. Why is that important? Well, we know that we have a problem with a significant amount of information that either we misdiagnoses. We talked about medical errors in the beginning. We either misdiagnoses or we don't connect the dots when we look at X-rays or CAT scans or MRIs. So there is a need to change the way that we interpret information and bring all of the the metadata together in order to make the best diagnosis. And Merge is an example of this. I'm not going to steal their thunder. They're always presenting at RSNA or their imaging conferences, and you guys can go read up on them. The final piece is Watson. So it's IBM Watson Health. So Watson, as I mentioned earlier, won in Jeopardy. It won in Jeopardy by reading a whole bunch of books and becoming smarter in terms of recall, and in terms of being able to discern and generate different hypotheses. And bringing that together into the health pillar, if you will, is our way of saying that there's a lot of information that none of us as humans can just to know. So we're going to use Watson, and we have been using Watson, and I'll give you some examples in a few minutes. Now, who do we serve? Watson Health, it's not called Watson Healthcare, it's called Watson Health. We serve anyone and everyone in the health ecosystem, whether it's academics, and we have a number of partnerships, whether it's other industries. So IBM has a long history of being a cooperation type of company. We will be more than happy to work with folks and then walk out of the room and put some boxing gloves on and compete in the market. That's IBM's legacy. We are also serving the life sciences industry where a lot of innovation happens. And of course, we have a large, through our Truven acquisition, a large government business. And then we have health plans that we serve as well. Now, going back to Explorys for just a moment. When people ask me, well, okay, you have Explorys, so you have this large data set, what does it represent? It represents approximately 400 acute care facilities, about 64 million patients. And why are those numbers important? Well, we know, and the statisticians in the room know, and what I'm not a researcher anymore. I dabble, but I sort of put that life aside when I left the Cleveland Clinic to take this role on and spin out Explorys, is that numbers matter for certain things. Of course, the quality of the data matters for things as well, but sometimes you can overcome some of the noise if you have a large enough number. And that's why these numbers are up here. We also know that we can't do it alone. I talked about earlier that Watson Health is happy to work with folks. We know that we have pockets and we have gaps we have pockets of expertise and data, and we have gaps in expertise and data. So we have built a number of partnerships in our short 18 months that we've been around, whether it's with Medtronic, helping predict hypoglycemia in diabetic patients through continuous glucose monitoring, or whether it's with Johnson & Johnson, predicting post-operative complications, or whether it's some of our most recent partnerships with the VA, looking at precision medicine, or the American Diabetes Association, the American Cancer Society, the American Heart Association, looking at Under Armour. I don't know how many of you are wearing any of their devices or any of their clothing, but many of these companies are not content, for good reasons, of being just a sports brand or a clothing company. They know that they have the ability to start generating data that's going to help their customers be better athletes or to be better consumers or healthier consumers. And IBM is very interested in that space. And of course, we have partnerships with pharmaceutical companies and such. Now, the other thing is that IBM is a very, very large employer. And after our salary from an operating expense, our next biggest expense is healthcare. So when you have 370,000 employees, not only do you want to be serving the healthcare and health market, but you want to be a recipient of it. So IBM, along with 19 other large companies, formed something called the Health Transformation Alliance. And the goal here is that we need to change the way we look at efficiencies in the market. IBM is a large employer, and whatever we do to change the cost curve is going to benefit us as well. We want to learn from the data, and we're going to come back to that point. We want to make sure that every employee is as educated as they can on health and wellness. That's why I have a watch on. I got a deductible on my premium, or a rebate back on my healthcare premium by wearing this, so we can understand how much I exercise and walk. And I might do some pacing depending on what alert I get on my watch. We'll see. But in terms of looking at the employees, we also need to basically break bad habits. Now, we know healthcare systems have toyed around with not hiring smokers. For example, my organization, Cleveland Clinic, where I practice, doesn't hire smokers. We do nicotine level tests on them to make sure that they're not smoking. And if it's an existing employee, we'll do everything we can to help them quit. But we also have to break habits that exist among non-healthcare employers. That's the way you tend to change the cost curve. Now, I told you I had something for everyone. So the technologists in the room, you need a platform slide. So this is a platform slide. On top is who we serve. On the very bottom is where the data comes from. And I'll make some of these slides available so anyone who's trying to squint or take pictures, I will let you know if there's a slide that we won't include, but this will be included in the slides. And you see at the very bottom that we need data, and you cannot generate a complete picture of a patient by looking at just the claims data or just the EMR data. You need to get the data from everywhere. And most of us, when we experience health in a very fragmented way. We go to labs over here, we go to primary doctors over here, we go to hospitals over there. So we need to all bring it into a single data lake. And once we bring it into a single data lake, we need to then use big data analytic tools to be able to do it very, very quickly, because the days of doing things every week, every month, you can't make changes in behavior by using old information. So it needs to be done very, very quickly. We also need to make sure that we know that when Mr. Jones came in to the hospital, he's the same Mr. Jones that came in through the emergency department and the same one I saw last week in my office. We need to identify patients across the community. In the US, a lot of countries find this difficult to believe. In the US, we don't have a national patient identifier. We have no way. People have built an entire research careers trying to figure out how to link these different folks together. It's insane, but it is who we are as Americans. And I don't know if the election will change any of that, but that is something we have to live with, is that we don't have a patient identifier that's across the community. We also don't know how to best represent data from a regulatory point of view when you have HIPAA and high tech and all these different rules. So we have to do things to the data to make it consumable. We also have to make sure that if we're going to use it for patient care, it's on one end of it, and if we're going to use it for research, it's a completely different end of it. So there has to be firewalls, if you will. Now, I always tell people, what kind of data are you talking about here? Well, we have data, and I'll just point out some of the unique data. And of course, my colleagues in other industries will have a very similar type of story. But one of the areas where we're seeing a huge amount of emphasis is on patient-reported outcomes. Great, you know what the doc did. You know how the patient experienced in terms of blood pressure lowering or cholesterol lowering. But how do they feel? How was their pain? Were they less depressed? So the patient-reported outcomes are an incredibly important part of our focus. Market Scan, you guys are all probably very familiar with Market Scan, but they have the payment and value side of it, and understanding the relationship between those who are paying, like the employers and government, and those who are generating the bills, if you will. Now, this is for the data scientists in the room who love R squared and MAPES. So one of the things you can do when you start bringing data together, the clinical data and the traditional administrative data, is that you can start building better algorithms, better predictive algorithms. And this is an example of where our healthcare clients said, look, I don't want to take my most expensive resources and apply them to every patient I have. Tell me who is going to consume the most dollars. And we are able to produce and create risk models like this. This has been validated by Milliman, a large actuarial firm. And the idea being that if you combine more data, you can start making better outcomes, better than some of our competitors. And then you can start putting things like this up, where you can tell health systems, where are their patients, where are their sickest patients, where are their clinics, and do they connect the clinics with where their patients need services. Disease burdens, and using risk scores to help them understand the different priorities of where the clinical and the administrative risks are. Then helping them understand, I think I heard earlier comments about implementation. Watson Health is all about solutions that change behavior of the patient and of the provider, whether it's in the mobile or whether it's in a traditional software as a service offering on a desktop. And the idea being that we need to be able to embed the different risk scores and scorecards and the various, quote, alerts into the system so that we are actually changing behavior. But we all know that the traditional alerting mechanisms in EMRs is broken. We can spend a lot of time talking about that. But the way that we're approaching this is that we want to minimize the amount of data being thrown at a doc and maximize the amount of actionable information. That's our goal. These are just examples using visual color schemes, using very clean and crisp tests, and then letting them drive and dive deeper when they need it. One of the things we talked earlier about, and it's important for us to understand that any company that does work with large amounts of data has to have a very keen management of privacy and security. And this is an example of the balance between creating HIPAA compliant, completely safe harbor data sets, and then statistically de-identified data sets. And that's pretty much all I'm going to say about this, but there is more information. You can feel free to reach out to me, and I can give you more. But one of the areas where I see our data scientists and data scientists we work with in our client organizations, they have this tendency to want to combine data with everything. And keep in mind that when you have statistically de-identified data sets or de-identified data sets in general, the whole act of trying to link it with other things could reintroduce risk of re-identification. So these are things that you should get really familiar with. Understand HIPAA's de-identification rules very, very clearly if you're working with large amounts of data. Now, what's cognitive? What's Watson? So Watson is a cognitive computing platform. And Watson can understand, it can reason, it can learn and adapt. Now, Watson's not a person, obviously, it's a system. It's a bunch of algorithms and computers that can bring in all this information and do this. Now, why is that important? What's missing on this slide is that Watson doesn't have creativity. It doesn't imagine, it doesn't dream. It doesn't have personal motivations. So humans cannot, and this is important, whenever someone asks me what AI is, I don't say it's artificial intelligence, I say it's augmented intelligence. Humans did program the system. Humans are training the system. The wealth of knowledge that humans created are what's fueling Watson. But Watson isn't going to replace some of the things that make us human. And that's an important part of continuing to innovate and deliver in health. Here's an example of something that many of us, are there any practitioners in the room, people who see patients? Tell me about your problem lists. Is it a high quality problem list? No. If you ask a lot of practicing docs at various systems, they say the problem list is a terrible place to really understand the problems that a patient has. One of the first areas that we used Watson to tackle was, can we improve the problem list? Can you take all the unstructured data, read all those notes, combine it with circumstantial data from other places, and create a better problem list? And this is just some data that shows that we can create a better problem list. Is it perfect? Am I going to make treatment decisions based on what Watson is telling me about the patient's problems? No, but it's going to help augment the way I might manage a patient. So we're making significant progress in creating a better problem list. And because everything else starts from the problem list, all the care gaps, all the quality improvement, what I prescribe starts with that, it's important we wanted to start there. But it doesn't end there. We can also flip it to the other side of the spectrum, which is, how do I know that I'm offering every one of my cancer patients the best treatment possible? So this was just from a couple weeks ago. Last week, 60 Minutes ran a story on this. Dr. Sharpless at the University of North Carolina worked with IBM, Watson Health, to do a study where they looked at 1,000 patients that had gone through a tumor board. And the Watson Health systems, by reading the literature, by understanding the patient's characteristics, found 300 additional patients that should have been offered a potential treatment. Now, it doesn't mean that they're going to be cured. It doesn't mean that they're going to have a better quality of life. But these are things that are steps along the way of a cognitive journey where there's just so much information that we just can't manage to make all the right decisions at all the right time. A personal story, I had a kidney stone a few years back. And after I recovered and went back to work, every patient with back pain, I was worried about whether they had a kidney stone. And a few of those cases, I actually ordered x-rays to make sure they didn't. And we are biased as humans by our experiences and what we have done last night and what we have done last week, whereas the computer system isn't. And if we're going to change the way healthcare is delivered in a more standardized, evidence-based, precision way at times, we need to make sure that we are using the right voice at the right time. Here's another example. You guys are all familiar with evidence-based medicine and standardized care flows. Well, how do we know that a doctor who deviates from that isn't actually doing better medicine? Sometimes variation in care is not bad, it's good. That's what creates innovation. So if you had a system like our Watson Health care flow capabilities where you can go through every single branching logic and see what was the desired outcome and what path led them to that. Now, this is early, this is a research asset, but the idea that we can look at a whole bunch of real world data and come up with some different paths is really important to us, because sometimes as you guys all know, the literature is filled with things that we thought were right and only to discover that they're wrong. And sometimes it's a brave resident physician or a young junior attending who makes the right decision that we only find out about through retrospective analyses like this. So I want to make sure we all leave with the idea that the industry in general has a huge opportunity right now. We, of course, at IBM think this is critical. A lot of change happening in healthcare, and we're going to sort of create an opportunity to help our health systems, help our life science organizations address it. And we may have an initial focus on data analytics. It's an area, especially if you focus on choosing wisely or some of the quality measures that are non-controversial, it's easy. But what's hard is when you start to change the care paths, and that's an important part of what we're trying to do. We want to make sure that we never leave it in the lab. It's great if you find something interesting, but you got to make it actionable. Sometimes making it actionable when there's so much information in our heads requires cognitive, requires some augmented intelligence platform for us to be able to make it actionable. And I'll leave with that. Thank you. Any questions?
You know, as someone who's old enough to remember the IBM from the 60s and machines from that day, I thought I would kick us off with sort of a technology question that has been worrying me for a while. And in healthcare in particular, you know, we've seen such a proliferation of software in the last couple of decades, propelled by high tech and all of the other various acts, and you know, this march towards digitization. And Watson Health is another example of a platform that many have argued, others have argued in the industry is going to solve all the problems of healthcare. So I would love to hear your perspective on this proliferation of machines and software, and are we ever going to get to the day where all of this works together seamlessly?
Great question, Ritu. I think what you're referring to is this false illusion of interoperability. And you know, the government has spent
the I word.
the government has spent of our taxpayer money significant amounts to try to bring some closure to the interoperability. I think there is a great deal of advances in technical interoperability, but very little on semantic interoperability. And that's for us all to solve. I think Watson Health is certainly doing our role. We have lots of smart people that are part of our organization involved with some of these think tanks and organizations. At the end of the day, who's going to push industry into interoperability is our clients, who see a need for having integrated solutions. There's nothing like a company that is a publicly held company like IBM, who have shareholders, who have clients. We are motivated by changing the world, but we are also motivated by who's going to buy what and why. So interoperability needs to be made part of the requirements for any solution. The other part of it is that there are areas where we want to compete and areas where we want to cooperate. We want to cooperate on interoperability. There is no value of having a black box. It's hard to validate. It's hard for you guys to accept. And whether the black box is around the data or the algorithms. The data, it's hard to compete because we've just made an argument for why the data needs to come together. But I think it is getting better. Do I see a specific day in the future? No. I think there'll be incremental progress. I don't see a significant amount of legislation or policy that are going to push it any more than they already have. It's going to be the consumers saying, I do want to share my data. And right now, some of the trend that we see is the other way around. We want to keep our data close. So it's really going to be the consumer and the customer.
So Dr. Jain, a great talk. Just wonder from a physician perspective, do you see that one day Watson Health will replace my primary care physician? It will actually perform better than a general doctor?
I have no doubt that Watson will make some better decisions than I do, especially if I've been on call the night before or I've had a busy set of cases in the morning. But will Watson ever replace a doctor? The answer is no. Watson is like my stethoscope. It is going to help me listen to the heart better. It's going to help me create a relationship with the patient, the art of healing, if you will. And I do envision a day where every patient is going to say, Doc, do you have Watson helping you? And maybe it's not Watson, maybe it's someone else. I don't want to make this totally about Watson, but we're certainly pioneering in this area. Just like none of you would accept a doctor telling you that you have a leakage of your heart valve without first getting an echocardiogram. It's the same way. I think that there's going to be a point where we will not allow someone to get life-threatening, very expensive treatment without getting a, quote, second opinion from Watson.
Last question.
Enjoyed your presentation. I want to get your thoughts on the role of wearables and mobile devices and how that fits into Watson Health's Watson Health's schema for collecting data from non-traditional sources.
Yes, a great question. So one of the areas to try to abbreviate this talk that I dropped was some of the work we're doing with consumers. So Under Armour is an example of one company, but we have a partnership with Apple to get Health Kit and Research Kit. And as the wearables start to standardize how they interoperate and bring in data, we are in the middle of all that. And we think that just like we mentioned, 10% of the data is clinical and 30% is genomic. Our habits, especially how we're doing from a exercise point of view, our heart rates, our diet, is going to come from our wearables, and I think it will be a huge explosion on non-intrusive wearables. Today, my wife is a Fitbit wearer, I'm an Apple Watch wearer. We all have our reasons for what we do, but most people will say that we're at the early adoption stage and not at the ubiquitous stage. Pretty soon we'll be at the ubiquitous stage when it becomes innocuous. You buy a sweatshirt and it's got everything built in, we're not even aware of it. Or you wear a watch, it's serving as the watch, but it's also doing a whole bunch of other things around the table. And bringing all that data in near real time. Not so that you can send it to the PCP who's going to be inundated with this data, but so that you can use analytics to figure out signals that make a difference and alert the doc, alert the emergency department that this person is not doing well. There's a recent study where they were able to prevent a whole bunch of folks from getting life-threatening anticoagulation because they were able to find out exactly when they went into atrial fibrillation by looking at their Fitbit data. Okay, so this is going to change everything. What we also want to make sure is that there's not a bunch of haves and have-nots. Some of our biggest pressing challenges in healthcare have to do with folks who may not always have the same access, and so we don't want to create another problem in this journey. Thank you.
All right, thank you very much, Dr. Jain. Just a fascinating talk, and the future is wide open. We're going to take a quick break and start the next session at 11, the first research session of the day. So I'll ask those members of that session to come forward, and we'll start again in about 5-6 minutes to get back on time. Thank you.